Hi, this is Cameron Black. I'm going to talk about common pulmonary scenarios, respiratory issues that you may encounter while on call or covering at night or even with your patients during the daytime. But, kind of straightforward, simple things that are related to respiratory problems. I'm a PGY5, one of the current chief residents. Just as an overview, I want to approach this topic and kind of look at it as a basis of symptoms, or at least presenting problems that you may get called about. Because a lot of times you aren't told what the diagnosis is when a phone call comes in, but instead you're told the patient has some tachypnea or they feel short of breath and some of those kind of things. So it's good to think about what can cause each of these things. Now, none of this is a perfect match for every single symptom, but it's at least a way to kind of organize your thoughts and to look at a lot of these. First, looking at tachypnea. What sort of things do we encounter, especially on surgical patients, that can cause each of these symptoms? With tachypnea, this could be something like a pulmonary embolism. We know that in the postoperative period, people are much likelier to have pulmonary emboli than just random standard patients that haven't had surgery. Sepsis is a major cause of tachypnea. It also can be secondary to additional issues that we'll list here with some of the other symptoms. Shortness of breath. This could be very subjective. A patient can feel short of breath, but there might be something more objective about it. This might be related to anxiety. It might be from splinting, from pain that people are having. They aren't able to take a deep breath. They feel like they are short of breath because of this. They might have an underlying pneumothorax or other pulmonary pathology. A lot of the other issues that we're going to talk about can cause someone to feel short of breath. They may have some wheezing, so it might be an asthma-related issue. Next would be a cough. If somebody's coughing, either it's a productive cough or a wet cough. This could be pneumonia, it could be pulmonary edema, respiratory infection. Dry cough, this could be bronchitis, a viral infection. You can commonly get a dry cough with a pulmonary embolism or a pneumothorax, things that are irritating to the pleura, or additionally some inhaled irritants. We'll talk a little bit more about each of these. Hypoxia. We'll often get called about a patient who has previously not required any oxygen supplementation, but now their saturation's low when they check their vitals, or they're on a continuous pulse ox and their oxygen saturation is dropping. This, though it's not really a symptom or something, but it's more of an objective finding, but it certainly can be the first thing you're called about. Otherwise patient's doing well, but now they're requiring a little bit of an increase in their oxygen needs. They're becoming more hypoxic. This can be a large variety of things. Most common in the postoperative period, we can see atelectasis, but you can also see it with sleep apnea, congestive heart failure with pulmonary edema, respiratory distress syndrome, pneumonia, COPD, many others as well. And then you have hypercapnia. This would be high CO2. This is not something you're going to just get called about, but some of the symptoms that go along with hypercapnia would be an altered mental status, a patient who is more somnolent, difficult to arouse, more sleepy, those kind of things. And this would be more of a laboratory finding on a blood gas. But the different things that can cause that would be obesity, hypoventilation, COPD issues. More baseline, people can be CO2 retaining at baseline in their normal, stable disease state, or it could be an exacerbation of their underlying issues. And it can be a sign of an impending respiratory arrest, which is a very ominous sign. So how do you work this up? You get called about that complaint, whether it's tachypnea, shortness of breath, cough, hypoxia, hypercapnia, or even other things related to respiratory issues. How do you work this up? And certainly if any doubt is in there, or if, certainly early on in your intern year, you're going to want to go see the patient first. You get a little bit of information from the nurse. You can usually start to triage things, as with any of the other common intern scenarios that we talk about. You're going to have to triage things if you're already busy with something else that's going on. If you're already seeing a more critical patient or in the middle of a procedure or something, you have to figure out if this is something that's an imminent risk to the patient, or if you have a few minutes to gather your thoughts, to look at the patient's chart, or to finish what you're doing before heading there. Nursing staff, they're variable, of course, but there are some amazing nurses that will give you a lot of input. It's never a bad thing to kind of check with the nurse to see if they think this is an emergency, if it's something urgent, but you can kind of finish what you're in the middle of and then get up there soon, or if it's something more routine. Now, of course, as you get to know different nursing staff, you can understand if their assessment, if maybe they're overreaching, if they are, overreacting to something that's maybe not as big a deal, or vice versa, that they're not recognizing a big problem. You have to, it's always safer to be more aggressive and more suspicious, but either way, early on, the best move is to always go see the patient, see them for yourself. Sometimes the numbers or the simple complaint of a cough is not exactly what the patient looks like. You go in and you can see that they just don't look right. There's something more to it. Seeing the patient, and then for pulmonary issues, we start with checking an O2 sat, checking their respiratory rate, other vital signs like their temperature, their heart rate, their blood pressure, etc. That can start to give you a picture of what's going on. Performing an examination, listening to their lungs, just a visual examination is almost the most important thing with respiratory issues. If they look like they're, barely keeping up, they're working really hard to breathe, it's everything they can do to just stay above water. I guess I didn't mention here, but a history is important as well. What kind of patient is this? What medical problems do they have? What recent things have they undergone surgery-wise or procedures? That'll really clue you into some of the things that can cause the symptoms we've just mentioned. And then your workup can include imaging and labs. Common for routine respiratory issues would be getting a chest x-ray. That's not something you should just routinely order every single time you get called about a minor respiratory complaint. But certainly if you're in doubt about what's going on, or if it seems to be a significant change, that will help start the workup. Getting some labs. An ABG, it's not a minor routine lab. It requires an arterial stick, so it's a little more painful, but it does give a lot of great information. Certainly somebody who's having a lot of respiratory issues that it's hard to tell what's going on, you want to know how severe they are. An ABG can be a really helpful tool to differentiate different types of respiratory issues. You can get other labs, metabolic panel, a BNP, a brain natriuretic peptide. That really is helpful in the setting of congestive heart failure or volume overload. A CBC, these can clue you into some of the other differential that we will talk about here in a minute. An EKG could play in, especially in the setting of heart issues that may be manifesting more as respiratory issues. Getting a CT chest or CT PE study. Again, this would be important if it's specifically what you're worried about, a PE, or a VQ scan if that's more indicated, somebody who's allergic to IV contrast. So I want to go back through each of those that we talked about and then kind of break down each of those things. And I don't claim that this is an exhaustive list or that everything we talk about here is exactly how you should do it, but it'll give you a general idea of how to kind of approach these things and hopefully a place to start. And that's the idea of these podcasts in general. So tachypnea, somebody who's breathing rapidly. Pulmonary embolism is one of the things that we always worry about in a surgical patient. It should always be on your differential. Whether it's not number one, it's definitely one you're worried about, and you kind of need to rule it out, if you will. So somebody who has chest pain, shortness of breath, tachycardia, there's a lot of different symptoms that can, signs and symptoms of a pulmonary embolism. Tachypnea, again, is only one of those, but I just have listed it here. How do you work up? Well, you have to kind of have an index of suspicion. Certainly a patient who's had a major surgery, maybe they've not been on anticoagulation, perhaps they've had a bleeding risk or something. That would be relatively high risk. If they have signs that they've had DVT, whether it's leg swelling, but that by itself isn't as reliable. People can have PEs without any other symptoms. Workup for this, a CT PE scan or a VQ scan to look at the lungs to check the perfusion. That's the gold standard, getting a CT PE study. You don't want to just routinely order this on every single patient that has a little bit of tachypnea or something, but if the puzzle pieces fit, if the patient seems to be someone that's high risk for thromboembolism, and you're quite worried about it, then again, usually it's better safe than sorry to check for these kind of things. As with most respiratory issues, if they seem severe enough to be getting advanced imaging or doing significant treatments, this is when you should already be involving the senior resident that's on call with you, and they usually are also involving the attending physician that's at home on call. So this isn't something you usually, or certainly early in the year, are ordering CT-PE studies on every patient who has some respiratory problems. But again, that's the gold standard for workup here. Additionally, getting a venous duplex is a potential. Now that doesn't, just because somebody had a PE doesn't mean you're going to find DVT on venous duplex. By itself, it's not a mandatory part of the workup of a PE, but it can help you understand where this may have come from. It also help you with surveillance for their DVT and on down the line to see if it's gotten worse or better. As far as treatment, the mainstay of treatment for a PE is to do anticoagulation. It would be a whole lecture in and of itself to talk about massive PEs and submassive PEs and the different and more aggressive treatments like thrombolytics and stuff. But ultimately, most surgical patients, if they develop a PE and they're stable, it's going to require anticoagulation, and it'll be a long-term anticoagulation. But on call, that's something you'd basically usually just initiate something like a heparin drip, immediate anticoagulation. The long-term stuff would come later with more planning with, talking with the attendings and teams and things like that. I put a question mark on a filter there. Patients who cannot have anticoagulation, such as like a trauma patient who had a subdural hemorrhage, or some of these kind of scenarios we run into where they can't get any anticoagulation at all. We can do what's called an IVC filter. That's usually more for patients who have a DVT, haven't yet had the PE, and you want to prevent the pulmonary embolism. That's a filter that goes in the vena cava to prevent DVTs from the lower body causing a PE. Next one listed here is sepsis. Sepsis being a severe infection with kind of a systemic inflammatory response. There's, of course, all of sepsis criteria and things, and I know there's some other talks in this series that are going to talk a little bit more about infection and things like that. So I won't go into all the details of sepsis, but it's important to remember that severe infection can cause tachypnea. Your body's response to sepsis, one of the most common is, especially as you're acidotic, is to try to blow off more CO2. It's a natural reflex, and people become more and more tachypnic. They can even become tachypnic beyond just blowing off CO2 and become actually slightly alkalotic from that. Any sepsis workup is going to involve, your suspicion of the site and origin of the infection. But ultimately, if somebody's tachypnic from sepsis, this is likely a pretty serious condition and is going to require more advanced treatment, such as transfer to the ICU, broad spectrum antibiotics and cultures, and potential for even intubation if they're really that sick that they're getting quite tachypnic. So keep in mind that if a patient is breathing very rapidly and appears to be tiring out from this, that could be a red flag for kind of an impending respiratory arrest, and that's not something that is easily taken care of in a normal hospital room on the normal floor with untrained nursing staff. Usually by that point, it's much better to have had the patient in the ICU and to perform an intubation in a controlled setting. And again, of course, this is something that an on-call senior resident would be dealing with a lot more than an early intern. And then I say secondary to additional issues, you can be tachypnic for a lot of other issues that we're going to talk about here, pneumothorax and other kind of issues, treating those in their specific way, as we'll talk about. So shortness of breath, the next symptom you might get called about. A lot of different causes of this, and again, there's a lot of secondary issues that can cause shortness of breath that we'll talk about as well. I mentioned subjective anxiety. That's probably the most common. People feel anxious, they feel short of breath, but maybe they're not hypoxic. Other labs and vitals and objective findings are all normal. We see this not uncommonly, and treatment with anxiolytic medication is appropriate if that's the case. I wouldn't just start treating people's anxiety initially, but if they have that history, if they take medication at home, it's not unreasonable. What's important to remember with some of these more benign things causing some of these symptoms is don't assume that it's something minor. One of our old program directors used to always say, the first thing you should be worried about is what is going to kill the patient. And keep that in mind. Whenever you get called about a patient, what's going to kill my patient that could be causing the symptoms I'm being told about? And so in this case, don't ignore other problems and just assume it's anxiety. Even if the nurse suggests that, you won't uncommonly hear a nurse say, the patient seems kind of anxious. Do you mind if we get a medication to help with that? It's easy to say, sure, why not? But you got to have a certain index of suspicion and just keep your differential in mind. It's more of a diagnosis of exclusion when everything else that's more serious has been weeded out. Splinting from pain, same kind of idea. Somebody might feel short of breath, or they might get hypoxic because they're not breathing deep enough. And ultimately, surgical patients have a good reason to. If they have a large abdominal incision and they're not able to take a deep breath because it hurts, and so they're either consciously or subconsciously not breathing deeply, you can get a lot of respiratory issues from that. But don't just assume it's pain if there's other things that are going on, or if the patient's symptoms and things more objective, like their vital signs, are concerning. But if the nurse calls, says the patient's in quite a bit of pain and they feel short of breath, it's not unreasonable to try a little bit of pain medicine to see if that helps. Again, but this is something to keep in mind. Don't ignore more serious problems. It's more of a diagnosis of exclusion. A pneumothorax. That's something we see not infrequently, because in surgery we're doing a lot of procedures, but we also cover trauma patients, and traumas are those that, probably the most common population that end up with a pneumothorax. Certainly the history of the patient will help you the most to understand whether this would be a possible pneumothorax. Somebody who's had a procedure like a central line, and an upper vein like an IJ or a subclavian central line, something that's after like a pacemaker placement, a chest surgery, even like an abdominal surgery, but one that's in the foregut. So you're working on the esophagus or the stomach. You're up near the diaphragm. These could all be potential causes of a pneumothorax. A biopsy, if somebody's had a lung biopsy or they've had a thoracentesis, these could ultimately result in a pneumothorax. Or somebody who's been intubated, you can have barotrauma. But most commonly, of course, in a trauma patient, rib fractures or other chest trauma, penetrating chest trauma, that's caused a pneumothorax. Usually those are pretty easy to catch, because the patient comes in that way, or you certainly are suspecting it and working it up in your trauma survey, and that's a completely different set of lectures, of course. But in the floor patient who's had a procedure done, maybe the interventional radiology team or the cardiac team have done some procedure, and now the patient's short of breath a little bit later on, that might be a little more difficult to pick up clinically. Ultimately, gold standard for checking this is going to be to get a chest x-ray to figure it out. Now, a massive pneumothorax can cause a tension pneumothorax, which is obviously a major concern. It's an emergent situation. And without going into too much detail on the differences there, ultimately you should be able to pick up a pneumothorax that's significant like this by auscultation. They have distant and diminished lung sounds, and then a chest x-ray showing a collapsed lung. Treatment for this is a thoracostomy tube. If it's an emergency situation where a patient seems unstable from a pneumothorax and you're worried about tension, then doing just a decompressive, a needle decompression. And again, we'll go through that in a lot more other topics. Now, somebody who feels short of breath, maybe they're also wheezing. This is maybe a patient who has a history of asthma, or they have a history of COPD. That's usually, not as maybe severe of a finding as a pneumothorax that we just finished talking about, or a pulmonary embolism. That one should be relatively easy to figure out from their history or by listening to their lungs. And usually treatment can also be somewhat diagnostic. In giving them a breathing treatment, doing a duonebs or an albuterol nebulizer treatment, having respiratory therapy come and work with them, usually you'll see a significant improvement if it really is a bronchospasm or some sort of asthma situation. So if they get a lot better with treatment, then you know that you're on the right track. And then I mentioned, secondary to other issues, so on finding and treating those that are causing it. A cough, you can have a wet cough or a dry cough. There's a lot of overlap between these, and the medicine guys might spend all day talking about differentials and stuff. But first talking about pneumonia, we don't see this uncommonly. Certainly patients who have had surgery or have intestinal issues are at higher risk for aspiration, or anyone who's been intubated in the ICU is at higher risk for pneumonia. Diagnosis on exam, chest x-ray or even labs, you see an elevated white blood cell count, you're looking for a reason for a fever, and then a chest x-ray shows consolidation within the lung. Treatment is an appropriate antibiotic, whether it's a community-acquired infection or hospital-acquired. Pulmonary edema can cause a cough. Somebody who has CHF, a diagnosis for this, a patient who has a history that would be suggestive, whether they've been in the hospital and received a lot of IV fluids for something like sepsis, or they've had a lot of fluid just for surgery and things, and they look at edematous on exam. Maybe they have a history of CHF with a low ejection fraction on their heart echo. You can get some labs that'll help with that, or chest X-ray. Chest X-ray will show, edema within the lung tissue. Natriuretic peptide with the setting of CHF is going to show an elevated BNP. Doing an echo, that's not something you're going to do in the middle of the night to check for pulmonary edema, but ultimately that's kind of part of the overall workup if somebody has a low ejection fraction. Treatment for this, if appropriate, to do diuresis. Now, if somebody has renal issues, if they're hypotensive, they're in the immediate postoperative period, diuretics are not a simple, straightforward treatment. So this is something that you would involve a more senior resident before just initiating a diuretic, but it's something to consider. Minimizing fluids or supporting them in their other symptoms, which may be more like hypoxia and things, giving them supplemental oxygen, positive pressure like a CPAP or BiPAP. Ultimately, some of these people may require ICU monitoring or even intubation if it's severe. An upper respiratory infection, viral infection can cause people to have nasal drip and cough, whether you're coughing up clear sputum versus purulent looking sputum. That can be the difference between a viral illness and a pneumonia. Certainly a appropriate clinical picture, history picture. If you got a chest X-ray and it's pretty clear, but they're coughing up clear sputum and they've had some fevers and it's flu season, or whatever, they've been around people that are sick, that kind of fits the clinical picture. And really, treatment for this type of stuff is just supportive. A dry cough usually is a little more benign than a wet cough, as long as you're not having some of these things like a pulmonary embolism or pneumothorax. But bronchitis, if they have COPD, if they have an exacerbation of that, maybe it's viral. Again, either treatment for appropriate things, whether it's nebulizers, antibiotics, or supportive treatment. A viral infection, same thing. Treat the same as an upper respiratory infection, or if it's a bacterial bronchitis or whatever. A pulmonary embolism, this may be your first symptom, is a cough. It could be the shortness of breath, it could be chest pain, it could be tachycardia, tachypnea, or a lot of these symptoms together. And the diagnosis treatment, as we've already mentioned. The same thing with pneumothorax. Irritants, somebody who in a trauma setting comes in with smoke inhalation and is coughing a lot, that's concerning. Smokers might just have a cough just chronically anyway. This could be a sign of aspiration, whether it's while they're eating they're coughing. So somebody who has swallowing problems, or somebody who has GERD and they're laying flat and they're coughing a little bit. Now, treatment for those are, each individual scenario is different, but if somebody has GERD, sitting them more upright. If they're aspirating when they eat, they probably shouldn't be eating until they get more of a thorough evaluation. Hypoxia. Now, this is probably one of the more common reasons to get called. Somebody's on a pulse ox, or they've checked their vital signs and their oxygen saturation has gone down, or they maybe have gone from needing no oxygen to needing a couple liters, or from a couple liters to 4 or 5 liters. You'll sometimes get the distressing call that they've gone from 2 liters to 4 to 6. Now they're on a non-rebreather, and we just decided to call you now. And that's not uncommon as well, that they've escalated the oxygen use a lot before you've been notified. And depending on each of those is, how urgent things are. If someone went from 2 liters to 3 liters, probably not the biggest change. But someone who's gone from room air and now they're on a non-rebreather, meaning they're getting 100% oxygen to keep their sats up, that's an emergency. So obviously each one's different, but there can be a lot of different things causing this. Atelectasis is the most common cause of respiratory issues in the postoperative period. This is most commonly caused by people who have pain, or they're not breathing deep enough after surgery. It can cause fever, and again, this is the most common early postoperative fever. Diagnosis with this, you can hear diminished lung sounds in the bases on auscultation. Chest X-ray will show collapsed lower lung fields. The treatment is usually pretty common sense treatments, trying to get them to breathe deeper, so using an incentive spirometer, getting them to ambulate, be out of bed, changing patient positioning, having them sit more upright or sit in a chair for meals, and making sure they have adequate pain control without being too much asleep. So it's a fine balance between they're snowed and they're not breathing deep because of that, or they're having so much pain that they can't breathe because they're splinting. Sleep apnea, this is usually a call at night. Somebody's desatting in the middle of the night. Usually the nurses can pick up on the reasons. The patient snores a lot, they have sleep apnea at home. Their history will give you important clues. They're obese, they already know they have sleep apnea, they snore a lot, that kind of stuff. On exam, you'd see that they're obese, maybe they have a large neck. And of course, they should be able to pick up, if they're on a continuous pulse oximeter, that the hypoxia is kind of intermittent. When they wake up and are told to take some deep breaths, they usually recover quickly. Treatment for this usually is going to be CPAP, and long term, of course, weight loss and some other more aggressive things. But in the short term, if they use a home CPAP, it's important to remember to order that after surgery. If we're admitting the patients, it's easy to forget that sort of thing. And you don't want to wait until their second or third night in the hospital when the nurse remembers or the patient happens to remember and calls you and says, hey, can we get their home CPAP ordered? Try to elicit that history from the patient and get that ordered at admission or as you're admitting them after surgery. Congestive heart failure, pulmonary edema causing hypoxia. That's probably the most common symptom you're going to see with those, more so than the cough and the other things we mentioned, but the diagnosis and treatment we've already mentioned. ARDS, that's a much more, you can almost think of it a little bit like pulmonary edema that's much more severe than just a CHF picture. Acute respiratory distress syndrome usually is in a setting of severe sepsis or trauma patients, other critical illness settings. If patients have had blood transfusions, you can get ARDS from that. This is a whole series of lecture in and of itself, and its treatment is complex, much more involved, requiring usually an ICU admission and ventilator management and things. Again, not something you're going to be dealing with on the floor, but if somebody's having significant respiratory issues and hypoxia, but they don't have a history that would suggest CHF, it could be the early stages of this type of situation. Again, by that point, a senior resident should be involved. The patient should be looking to be transferred to the ICU and that sort of thing. Pneumonia, as we've already talked about, and COPD as well. Now, hypercapnia, that's again not something you're going to find right on chief complaint or exam. Until you get labs, you're not going to really know about it. But the things you might see is somebody who is more lethargic, difficult to arouse, a low GCS. You get called by a nurse, this patient's just real sleepy, they have a hard time waking up. Maybe they're also having a little bit of hypoxia with it. These are all concerning things. Now, if you happen to get a routine set of labs that included an ABG for some reason, and the patient's otherwise fine, and you notice they have a high CO2, that might be some other more benign situations. But if in the setting of other respiratory issues or a patient that looks ill, you notice that they have a high CO2, that's usually a very concerning finding as far as respiratory is concerned. Obesity, hypoventilation is probably one of the more common causes of a high CO2. This is a large patient, morbidly obese, and can cause chronic hypercapnia. That or kind of COPD patients as well, very common. This is sometimes called Pickwickian syndrome. Large rotund patients with a very large abdominal mass. Basically, they have such a large mass that they're not able to have, to breathe deeply and have enough ventilation to blow off CO2, especially when they're in the hospital for other reasons, maybe not breathing as deeply, whether it's pain or pain medication related, so they're not breathing as much. Now they can get an exacerbation of this. It's not necessarily a benign finding in and of itself, because if they have anything that's causing their respiratory issues to be worse, now if they're obese and they already have some of this at baseline, now they're at much more risk. Any obese patient is at higher risk for, of course, a lot of complications, but respiratory is no different. I've seen patients where purely because they're big and they're laying on their back all day, they've required intubation and ICU stays and even tracheostomies and things like that, even though they had no other underlying lung problems. It's all just because of their weight. COPD, we've mentioned the diagnosis and treatment, but it's not uncommon for people to have baseline elevated CO2. Usually they've compensated so they're not acidotic from that, and that gets into a little bit more of the nuances of managing respiratory issues. Or it could be an exacerbation that's causing an elevated CO2. But important to remember that hypercapnia, if you do happen to get labs in the setting of other respiratory symptoms, and you notice they have hypercapnia, maybe they're tachypnic, they're hypoxic, their O2 requirements going up, and their CO2 is also elevated. This is a very ominous sign that basically if people are becoming hypercapnic, they're not ventilating enough. And this is where a septic patient, somebody who has maybe ARDS kind of in the early stages or have other things going on causing respiratory problems, they're more likely than not going to be intubated pretty soon. Sometimes these can get by with BiPAP, but again, before you're even to that point, you're involving a senior resident. This patient is likely going to be transferred to the ICU and have a lot more intensive nursing care and other people watching after them, because ultimately if you're hypercapnic with all these other issues, you're probably going to end up on the ventilator or something like that. So anyway, that's basically a quick overview. There's so many, subsets of all these problems and so many things that basically each topic can have a lecture in and of itself, but hopefully a quick overview to understand what you might commonly see. And the most important part is, if anything is more than routine, to look at the patient, to look at the history, to take it very seriously, and of course to involve senior residents when you are seeing something for your first few times and you're not sure of what you're dealing with. Anyway, thank you.